Hello friends, I am Dr. Anupama Devgan, your physiology faculty at Allen Next. I'll be discussing the PYQs of the FMGE exam. These are not just your PYQs, they're also your PYTs, the important topics which have been asked, and we will discuss them in detail. So let's see this. The first question is, which of the following is correct regarding oxytocin? Now, as far as oxytocin is concerned, oxytocin undergoes what is known as a neurosecretion. What do I mean by neurosecretion? Basically, oxytocin along with ADH is synthesized in the hypothalamus, in the neurons of the hypothalamus. There are two important hypothalamic nuclei which are involved. Once these hormones are synthesized, they are transported by axoplasmic transport into the posterior pituitary, and from the posterior pituitary, they come into the circulation. So this is what I mean by neurosecretion. Now, which are the two hypothalamic nuclei which are involved in the secretion of ADH and oxytocin? These are supraoptic and the paraventricular nuclei. 5/6 of ADH comes from supraoptic, so supraoptic mainly synthesizes ADH, and 1/6 of ADH comes from paraventricular. In the case of oxytocin, 5/6 is from paraventricular and 1/6 is from supraoptic. So if I ask you a question that which is the major hypothalamic nuclei involved in, if I ask you a question that which hypothalamic nucleus is involved in the secretion of ADH, your answer should be supraoptic. And if I ask you a question that which hypothalamic nucleus is mainly involved in the secretion of oxytocin, then your answer becomes paraventricular. Now, what are the actions of oxytocin? Oxytocin is responsible for what is known as the milk let-down reflex. Now, what do I mean by milk let-down? Oxytocin causes the contraction of the myoepithelial cells, which surround the ducts in the mammary glands. And contraction of these ducts will cause expression of milk, which is known as milk letdown, or also known as galactokinesis. So my first option, it is responsible for galactokinesis. This becomes correct. Can it be given by the oral route? No, this is a peptide hormone, so it will be digested. So it cannot be given by the oral route. It is secreted by the anterior pituitary? No, it is synthesized in the hypothalamus and secreted by the posterior pituitary. In higher doses, it has a diuretic-like action? No. ADH, which is the other hormone which undergoes neurosecretion, has an anti-diuretic action. Now, briefly, what is the difference between the action of prolactin and oxytocin? Both are involved in milk secretion, but like I just told you, oxytocin is responsible for the milk letdown reflex. And what is the action of prolactin? Prolactin is a hormone secreted from the anterior pituitary. And prolactin will increase the mRNA levels and subsequent production of casein and lactalbumin. Casein and lactalbumin are proteins which are present in milk. So prolactin increases the production of these proteins and therefore increases the milk secretion, whereas oxytocin is involved in the contraction of the myoepithelial cells surrounding the ducts and therefore involved in the milk let-down reflex. Another question, the hormone involved in the regulation of blood pressure, serotonin, histamine, angiotensin II. Angiotensin II definitely has a role to play in the regulation of blood pressure. Now, angiotensin 2 is secreted by what are known as the JG cells, juxtaglomerular cells. Sorry, once again. Let us see what are the stimuli which are involved in the secretion of renin. Because please understand, renin acts on angiotensinogen. Renin is secreted by the JG cells in the kidney, juxtaglomerular cells in the kidney. This acts on a protein which is present in the plasma, which is called angiotensinogen. And angiotensinogen now forms angiotensin 1. And angiotensin 1 is converted to angiotensin 2 by what is known as the ACE enzyme, angiotensin converting enzyme, which is present in the lungs. And angiotensin 2 is a very powerful vasoconstrictor. If it causes a peripheral vasoconstriction, it will increase the total peripheral resistance and increases blood pressure. Angiotensin 2 also decreases GFR, and angiotensin 2 will increase aldosterone. And what is the action of aldosterone? Aldosterone increases sodium reabsorption. So the point I'm trying to make is angiotensin 2 is regulated by renin. Any stimulus which increases renin will increase angiotensin 2. And what are the stimuli which will increase renin? Whenever there is hypovolemia due to any cause, loss of ECF volume, if there is hemorrhage, loss of blood volume, hypotension, dehydration, hyponatremia, even an increased sympathetic discharge. Increased sympathetic discharge will act on JG cells. There are adrenergic receptors on JG cells, and thereby there is going to be increase in renin. Anything which causes a decrease in the renal afferent arteriolar pressure, even a renal artery stenosis. But very importantly, the stimulus for release of renin is hypovolemia, hemorrhage, anything which is reducing the ECF volume. And what is the action of renin? Renin will increase angiotensin 2. Angiotensin 2 is a very powerful vasoconstrictor. By causing a vasoconstriction, it will increase the total peripheral resistance. And increasing the total peripheral resistance means it will increase the blood pressure and try to bring it as close to normal as possible. So the hormone involved in the regulation of blood pressure, answer becomes very simple. This is angiotensin 2. Again, just a brief recap of what we have just discussed. Renin is secreted by the JG cells in the kidney, acts on angiotensinogen, converts it into angiotensin 1, and this in turn is converted into angiotensin 2 by the ACE enzymes in the lungs. Very importantly, from a pharmacology point of view, we use ACE inhibitors to reduce blood pressure. Angiotensin 2, like I told you, is a very important vasoconstrictor, decreases GFR, decreases urine output, and because of vasoconstriction, increase in total peripheral resistance, there is going to be an increase in blood pressure. Angiotensin 2 will also act on the adrenal gland, where it increases the secretion of aldosterone, which causes sodium and water retention, helps to increase the ECF volume and restore the blood pressure. We can also use angiotensin receptor blockers to reduce blood pressure. Let's look at the next question. A mother complains of cramps in her breasts while breastfeeding her child. Which hormone is responsible for this? We've already discussed this, should not be a problem. This is oxytocin. Oxytocin is causing contraction of the myoepithelial cells surrounding the ducts, and that is what is responsible of cramps in her breasts. A cross-sectional view of the skeletal muscle fiber through the H zone would reveal the presence of. Now, let's briefly discuss what does a sarcomere look like. This is a Z line and this is another Z line. Between the two Z lines is the structural and the functional unit of the skeletal muscle, which is known as a sarcomere. Attached to the Z line are the thin filaments, which are actin. And then we have the thick filaments, which are myosin. And right in the middle of the sarcomere is another line, which is known as the M line. So extending from here to here, this is what is known as the A band. A stands for anisotropic to light. This is also known as the dark band or the A band. And what does this dark band or the A band consist of? This consists of myosin plus the overlapped actin. And on either side of the A band is the I band. I band is isotropic to light. This is also known as the light band. And what is the light band? This is only actin. And remember, half of I band lies in one sarcomere, half lies in a neighboring sarcomere. So if I look at a sarcomere consists of half of I band plus the A band plus half of I band. A band consists of myosin plus overlapped actin. A band consists of myosin plus overlapped actin. I band consists of only actin. Now within the A band, there is a slightly lighter area which is known as the H zone, and H zone has only myosin. So if a cross section is taken in the H zone, only myosin will be present. So if you can look at so let's see an electron microscope picture of the sarcomere. So here is one Z line. This is another Z line. What is A? A is the dark or the A band, which has got myosin plus overlapped actin. What is B? B is half of I band, and I band is only actin. C is of course a sarcomere extending between two Z lines. What is E? E is the complete I band. Half of I band is in one sarcomere, half in a neighboring sarcomere. And what is D? D is the H zone, slightly lighter area in the dark band. And what does the H zone consist of? H zone is only myosin. So a dark band, which is known as the A band, slightly lighter area, which is known as the H zone, and the lightest area is the I band. Let's look at the next question. Which of the following would help in explaining the mechanism of action of atrial natriuretic peptide? So basically this question is asking you which is the second messenger for atrial natriuretic peptide, and this should not be a problem. This is cyclic GMP. There are two hormones which use cyclic GMP as the second messenger, and that is ANP and BNP, atrial natriuretic peptide and brain natriuretic peptide. A very important topic for your FMGE exam are the second messengers. Which hormones use cyclic AMP as a second messenger? Which use cyclic GMP as a second messenger? So let's discuss them. Now, hormones using cyclic AMP as a second messenger: hypothalamic hormones, CRH, corticotropin releasing hormone, somatostatin. Anterior pituitary hormones, ACTH, TSH, FSH, LH. ADH, V2 receptor, uses cyclic AMP. Glucagon uses cyclic AMP. Catecholamines beta adrenergic response, a question which has been asked, uses cyclic AMP. Both hormones which are involved in, two hormones involved in calcium metabolism, parathormone, calcitonin, use cyclic AMP. Angiotensin II, which we've just discussed, uses cyclic AMP. So this list is extremely important because, like I said, these questions on second messenger are being asked again and again. Hormones using cyclic AMP, hormones using cyclic GMP as a second messenger, ANP and BNP. Hormones using phospholipase as the second messenger. Phospholipase means inositol triphosphate and diacyl glycerol. Hypothalamic hormones, TRH, GHRH, gonadotropin releasing hormone. ADH, but V1 and V3 receptors. V2 receptors use cyclic AMP. Oxytocin uses the phospholipase second messenger system, and catecholamines, the alpha adrenergic receptors, use the phospholipase second messenger system. Hormones which do not need second messenger, extremely important topic again. Growth hormone, IGF-1, prolactin, leptin, insulin. Leptin is secreted by the adipose tissue. Leptin produces satiety. Growth hormone, IGF, prolactin, leptin do not need a second messenger because they act via what is known as the JAK-STAT pathway. Insulin does not need a second messenger. This is because the insulin receptor itself has tyrosine kinase activity. So these are the hormones which do not need a second messenger. Let's look at the next question. Which of the following effects of puberty are not mediated by estrogen? Hair growth is definitely not under the effect of estrogen, but cervical mucus secretion, vaginal cornification, menstruation, all are done by estrogen. If the diameter of an artery is reduced to 1/3, by what value does the resistance of the artery increase? Now, resistance is inverse to the 4th power of radius. So if the radius, so let's see this. The question says that the radius here is reduced to 1/3. So that means 1/3 to the power of 4. That means it is inverse to 1 upon 3 3s are 9, 9 3s are 27, and 27 3s are 81. So this will be 81. So resistance increases by how many times? 81 times. 4th power of radius. Radius has become 1/3. So resistance is going to increase by 3 into 3 into 3 into 3. That is 81 times. So, two important laws of hemodynamics. What is hemodynamics? Hemodynamics refers to the principles of physics used to explain flow of blood. The first one is the Ohm's law. Ohm's law states that flow through a tube is equal to the pressure difference, the difference in pressure at the two ends of the tube, P1 minus P2, divided by resistance to flow. We can write this as flow is equal to delta P by R. Then there is something known as the Hagen-Poiseuille's law. Hagen-Poiseuille's law states that resistance is equal to 8 neta L over pi R4. What is neta? Neta is viscosity. What is L? Length. More the viscosity, more the resistance. More the length of the tube, more will be the resistance. And what is R? R is the radius. Resistance is inverse to the fourth power of radius, a question that we have just discussed. I can also substitute resistance in the first formula. So flow is equal to delta P by R. So in other words, this is delta P into pi R4 over 8 neta L, or pi by 8 into delta P R to the power 4 divided by neta L. In other words, flow is directly proportional to the pressure difference at the two ends of the tube. More the pressure difference, more the flow. Flow is directly proportional to the fourth power of radius. More the radius, more the flow. And it is inverse to viscosity. If viscosity is less, flow will be more. And it is inverse to the length. So these are two very important laws regarding hemodynamics, which you should be completely familiar with. Next question. Carotid body chemoreceptors are stimulated by all of the following types of hypoxia except. Now, carotid body chemoreceptors, these are your peripheral chemoreceptors. Peripheral chemoreceptors are carotid and aortic bodies. Very important stimuli for the peripheral chemoreceptors. Now, carotid bodies are 5 times more sensitive than the aortic bodies. And whenever the peripheral chemoreceptors are stimulated, the response is they will increase the rate and depth of ventilation. By increasing the rate and depth, we will increase the total or pulmonary ventilation, and this also increases the alveolar ventilation. Now, which are the stimuli for the peripheral chemoreceptors? The stimuli for the peripheral chemoreceptors is number 1, hypoxia, increase in PCO2, increase in H+, decrease in pH, increase in K+, increase in lactic acid, and even cyanide. These are the stimuli which will excite the chemoreceptors, and whenever the chemoreceptors are excited, there is an increase in rate and depth of ventilation. Now we know there are 4 types of hypoxia: anemic, stagnant, histotoxic, and hypoxic hypoxia. Now we know there are 4 types of hypoxia: hypoxic hypoxia, anemic hypoxia, stagnant hypoxia, and histotoxic hypoxia. Let's look at the 4 types of hypoxia and what are their features. The first is hypoxic hypoxia. Hypoxic hypoxia occurs in high altitude, or if there is a hypoventilation due to any cause. The cause of hypoventilation could be a bulbar infarct, an infarct in the medulla, Remember, respiratory center is in the medulla. So if there's an infarct in the medulla, hypoventilation. Or let's say Guillain-Barré syndrome, there is paralysis of the respiratory muscles. So hypoventilation due to any cause will result in hypoxic hypoxia. So what happens in hypoxic hypoxia? There is a decrease in the PO2. PO2 is the partial pressure of oxygen measured in millimeters of mercury. This refers to the dissolved oxygen in plasma. There is also a decrease in the saturation of hemoglobin with oxygen. There is a decrease in the oxygen content of the arterial blood. Will it cause a peripheral chemoreceptor stimulation? Yes. Remember, for the peripheral chemoreceptors, the decrease in dissolved oxygen, decrease in partial pressure of oxygen is the most important stimulus. So peripheral chemoreceptor stimulation will be present. The second is anemic hypoxia. In anemic hypoxia, the dissolved oxygen is normal. This is the characteristic feature of anemic hypoxia. In anemic hypoxia, there is no problem in respiratory exchange. There is no problem in the oxygen dissolved in the plasma. The problem lies with hemoglobin. Either the hemoglobin is reduced or the hemoglobin is normal, but its saturation is reduced. So in anemic hypoxia, the hemoglobin may be reduced with normal saturation, or hemoglobin is normal with decreased saturation. A condition which causes a decreased saturation is carbon monoxide poisoning, methemoglobinemia. Hemoglobin may be normal, but the saturation of hemoglobin with oxygen is reduced. Will there be any peripheral chemoreceptor stimulation? No, because here the PO2 is normal. Remember, peripheral chemoreceptors will be stimulated only if the PO2 is reduced. In stagnant hypoxia, like for example, which occurs in cardiac failure, there is an increase in the arteriovenous oxygen difference. Will there be any peripheral chemoreceptor stimulation? Yes. Why? I'll just explain it to you. Histotoxic hypoxia. Histotoxic hypoxia, where the tissues are unable to utilize oxygen, will be characterized by a decrease in the arteriovenous oxygen difference. Will there be a peripheral chemoreceptor stimulation? Yes. So let me explain stagnant hypoxia and histotoxic hypoxia to you. So let's see, what is stagnant hypoxia? When blood moves through a tissue capillary, this is the arterial side of a tissue capillary, this is a venous side. Arterial blood, the PO2 is 95 millimeters of mercury. Saturation of hemoglobin is 97 to 98%. And PCO2 is 40 millimeters of mercury. As blood passes through the capillary, the oxygen will diffuse from the capillary into the tissues and CO2 will, As the blood passes through the capillary, CO2 diffuses from the tissues into the blood and oxygen will diffuse from the blood into the tissues. So on the venous side, the PO2 reduces to 40. Saturation of hemoglobin is 75%. And the PCO2 will increase to 45 millimeters of mercury. As you can see over here, there is an arteriovenous oxygen difference. The arterial side PO2 is 95, venous side 40, 55 millimeters of mercury. Arterial side saturation is 97 to 98. The venous side saturation is 75%, a reduction of approximately 25%. In stagnant hypoxia, as the blood flow through the tissue capillary reduces, stagnation of flow, decrease in flow rate, there is more time for the oxygen to be taken up by the tissues. So what will happen to the arteriovenous oxygen difference? Increases. Instead of 55 millimeters of mercury, the arteriovenous oxygen difference may be 70, 75, 80 millimeters of mercury. Arteriovenous oxygen difference increases. Now, why does it stimulate the peripheral chemoreceptors? Now, peripheral chemoreceptors, the carotid and the aortic bodies, they have a very, very high rate of blood flow. Extremely high rate of blood flow. Highest rate of blood flow is present in the carotid and the aortic bodies. So, if there is a decrease in the blood flow rate, like for example in cardiac failure, heart is not pumping blood effectively, so there is a decrease in the blood flow rate. This will decrease the total volume of blood, and therefore oxygen being delivered to the chemoreceptors in unit time, which now stimulates the carotid and the aortic bodies, the peripheral chemoreceptors. Total volume of blood and therefore oxygen reaching the peripheral chemoreceptors reduces, and that in turn stimulates the peripheral chemoreceptors. So this is why peripheral chemoreceptor stimulation will be seen even in stagnant hypoxia. Next, let's try and see what happens in histotoxic hypoxia. In histotoxic hypoxia, the tissues are unable to utilize oxygen. For example, cyanide poisoning. So what will happen now? Now the arteriovenous oxygen difference will reduce. The venous PO2 and saturation will increase because tissues are not able to use the oxygen. In histotoxic hypoxia, there is a decrease in the arteriovenous oxygen difference. So the normal arteriovenous oxygen difference is 55 millimeters of mercury. This now will reduce probably to 25 or 20 millimeters of mercury because there is increase in the venous O2 since the tissues have not been able to utilize the oxygen. So once again, in which type of hypoxia there is going to be a peripheral chemoreceptor stimulation? All except anemic. So once again, all types of hypoxia will cause a peripheral chemoreceptor stimulation except anemic. In histotoxic hypoxia, also there is a peripheral chemoreceptor stimulation because I told you cyanide, which causes histotoxicity, is a very important stimulus for the peripheral chemoreceptors. So agents causing histotoxicity directly stimulate the peripheral chemoreceptors. Anemic hypoxia is the only type of hypoxia where there is no peripheral chemoreceptor stimulation. Why? Because the PO2, arterial PO2, is normal. Insulin acts on glucose metabolism by insulin. The target cells for insulin are adipocytes, muscle cells, and liver. And what is the action of insulin? Insulin will increase the insertion of GLUT4 in these cells, in adipocytes and muscle cells. And GLUT4 is an example of facilitated diffusion. So insulin acts by increasing the facilitated diffusion of glucose. It will increase the permeability, not reduce it. Insulin does not affect the reabsorption of glucose from the renal tubules. The reabsorption of glucose in the renal tubules is insulin independent. And glucose absorption from the intestine is also insulin independent. So answer to this question is A. Briefly, let's see what are the actions of insulin. Actions of insulin can be divided into go actions and stop actions. Insulin will increase the glucose uptake in muscle and adipose tissue. It increases glycolysis, increases glycogen synthesis, increases lipogenesis, increases protein synthesis, increases the uptake of potassium and phosphate. It decreases gluconeogenesis, glucogenesis, lipolysis, ketogenesis, and proteolysis. Let's see the next question. What is the affinity of carbon monoxide to hemoglobin in comparison to oxygen? The affinity of carbon monoxide to hemoglobin is approximately 210 times the affinity of oxygen in hemoglobin. The closest answer here is C. See, we know that each mole of hemoglobin has got 4 heme, and each heme can bind an oxygen. When all 4 heme have an oxygen each, we say that hemoglobin is saturated. This is 100% saturation. This is oxyhemoglobin. In venous blood, hemoglobin shows a 75% saturation. That means out of the 4, 3 heme have an oxygen each, 1 does not. So hemoglobin is 75% saturated. This is unsaturated or hemoglobin or deoxyhemoglobin. Now, in carbon monoxide poisoning, if an individual is exposed to carbon monoxide, if he breathes in carbon monoxide, now carbon monoxide has a very high affinity. Hemoglobin has a very high affinity for carbon monoxide. So carbon monoxide will displace the oxygen and will get bound to heme. And like I said, the affinity of carbon monoxide and heme is 210 times the affinity of oxygen and heme. Very strong affinity. So once carbon monoxide binds with the heme, it cannot be displaced. It's like an irreversible combination. So what happens in carbon monoxide poisoning? What will happen to the saturation of arterial blood? Begins to reduce. Let's see the next question. Which pancreatic neuroendocrine tumor causes recurrent episodes of diarrhea, secretory diarrhea? And answer to this is a VIPoma. What is a VIPoma? VIP, firstly, this is secreted by cells in the pancreas, in the small intestine as well. Actions of VIP increases myocardial contractility, glycogenolysis. It decreases the HCl secretion in the stomach. Vasodilation lowers the blood pressure and causes relaxation of smooth muscle of trachea, stomach, gallbladder. It's a very potent smooth muscle relaxant. So, like I said, smooth muscle relaxation, that means vasodilation, lowering of blood pressure, and relaxation of smooth muscle elsewhere. Now, what is the action of a what is a VIPoma, also known as the Werner-Morrison syndrome? 90% of the VIPomas, they arise from pancreas, 10% can arise from other sites, colon, bronchus, adrenal gland, liver. VIPomas have somatostatin receptors. So that means I can use somatostatin analogues to reduce the secretion of VIP from a VIPoma. VIPoma is a tumor. There is abnormally high secretion of VIP. And because they have somatostatin receptors, we can use somatostatin analogues for treatment. The triad of a VIPoma is a secretory diarrhea. Because of the diarrhea, there will be electrolyte imbalance, especially potassium, hypokalemia, and hypochlorhydria or achlorhydria. Symptoms: watery diarrhea that persists with fasting. Stools are specifically tea-colored, odorless. Stool volume is very high, usually more than 700 ml per day, but in 70% of patients it can exceed almost 3 liters per day. Abdominal pain is not significant. It may be mild or absent. Next, potassium is maximally absorbed in which part of the nephron? Potassium, almost 60% of potassium is absorbed in the PCT. Now, potassium is one ion which is both reabsorbed and secreted. The reabsorption of potassium occurs in the PCT, where I told you almost 60% will be reabsorbed, and this reabsorption can be passive or it can be active. But which is the exact pump which is involved in the active reabsorption of potassium, we do not know. It is definitely not the sodium-potassium pump, because sodium-potassium pump is present on the basolateral membrane, not on the luminal membrane. Reabsorption of potassium can be in the thick ascending limb as well. There is a Na plus K plus 2Cl minus co-transport, which is a secondary active co-transport. The secretion of potassium occurs in the collecting duct, and this is a passive secretion, and this is under the control of aldosterone. Let's look at the next question. A 12-year-old girl is undergoing pubertal changes. Her Tanner stage is stage 4 for breast development and pubic hair scale. Which of the following pubertal changes is not due to estrogen? Vaginal cornification, yes. Cervical mucus production, yes. Menstruation, yes. But pubic and axillary growth is not by estrogen. Which of the following enzymes is responsible for the conversion of T4 to T3 in the peripheral tissues? Now, T4 is 3,5,3-5- tetraiodothyronine. In the peripheral tissues, it is converted to T3, which is 3,5,3-triiodothyronine. And this conversion of T4 to T3 is done by 5-deiodinase, which is also known as idothyronine deiodinase 1. Idothyronine deiodinase 2, which is also known as 5-deiodinase, is responsible for the conversion of T4 to reverse T3. What is reverse T3? Reverse T3 is 3,3-5-triiodothyronine. To convert T4 to RT3, iodine has to be removed from the 5 position. So 5-deiodinase does that. And 5-deiodinase is known as idothyronine deiodinase 2. Cervical dilatation and uterine contractions during delivery is similar to which of the following mechanisms? This is similar to milk ejection by oxytocin. Oxytocin is responsible also for the uterine contractions during the process of delivery. So, answer to this question, A. Let's see the next one. Which of the following is involved as a second messenger in the mechanism of gastric acid secretion? Gastric acid secretion, the second messenger is cyclic AMP. Let's see how does the secretion of HCl take place. Now, this is a parietal cell in the stomach. Parietal cells are involved in the secretion of acid. Parietal cells towards the lumen have a pump which is known as the H plus K plus ATPase pump. This is known as a proton pump. This is involved in the secretion of H plus. Now, the most important stimulus for the secretion of acid is gastrin. Gastrin is a hormone which is secreted from the G cells in the antrum. Gastrin comes via the blood, reaches the parietal cell. The gastrin receptor on the parietal cell is a CCKB receptor or a CCK2 receptor. How can gastrin act on a CCK receptor? This is because gastrin and CCK have a structural similarity. So the CCK receptor on the parietal cell is CCKB. So gastrin specifically acts on CCKB. The CCK receptor on the gallbladder is CCKA. Gastrin does not act on CCKA. CCKA has a greater affinity for CCK, cholecystokinin. CCKB has a greater affinity for gastrin. So when gastrin binds with CCKB receptor, there is increase in intracellular inositol triphosphate and calcium, which increases the activity of the protein kinases, and that in turn increases the activity of the proton pump, increasing the secretion of acid. Now, gastrin can also increase the secretion of histamine from the enterochromaffin-like cells. The histamine receptor on the parietal cell is an H2 receptor. The second messenger for the H2 receptor is cyclic AMP. And this in turn will increase the protein kinases and increase the activity of the proton pump. So the second messenger which is involved here is cyclic AMP. And inositol triphosphate as well. But since that is not in the options, your answer becomes cyclic AMP. So these were the questions which have been asked in your previous year's exams. Hope you found this session useful. If you have any questions, please feel free to mail them to me at Dr. Anupama Devgan @gmail.com, or you can send me a message on Messenger. My Facebook page is Dr. Anupama's Physiology. Thank you and all the best.